In this section, we're going to talk about the revenue cycle process, which includes billing, coding, and documentation. Here at GoHealth, our goal is to bill correctly for all the claims that we submit to any payer 100% of the time. That means that our documentation and our coding has to be right on every single claim that we submit to government or commercial payers. The orange wheel on your screen contains 3 steps that generally describe a compliant revenue cycle process. The first step in any revenue cycle process is documentation and medical record. The documentation in the medical record must accurately and thoroughly describe everything that happened during the patient encounter, because everything that goes into the patient encounter is reviewed in step 2 by our coders. Coders rely exclusively on the documentation that's provided in step 1 to assign what are known as CPT and ICD codes. CPT codes describe the procedures that we provide to patients, and ICD codes describe the conditions the patient presents with. All codes that are assigned to our claims must be completely and 100% substantiated by the documentation in the medical record. That means that basically the golden rule for compliant billing is if it wasn't documented, it wasn't done. If we bill for anything that's not fully substantiated in the medical record, that could be potentially problematic, including even considered fraudulent. Step 3 in the revenue cycle process is payment for services rendered. Everything that we get paid for must be fully coded accurately, and again, accurate coding is based on the documentation. So you see how it's a continual process from documentation to coding to payment, and every part must be completely accurate and done correctly in order to be paid correctly. The False Claims Act is the tool the government uses to fight fraud, waste, and abuse in the Medicare and Medicaid systems. If we didn't bill correctly based on the previous slide and we messed up any of the 3 steps in the revenue cycle process, which means we were potentially paid incorrectly, it could implicate the False Claims Act. The False Claims Act applies to Medicare and Medicaid and basically does the same thing if it's at the federal or state level, in that it makes it a crime to knowingly submit a claim to the government that's false or fraudulent in nature. The False Claims Act doesn't require any specific intent to defraud. That means that even honest mistakes can implicate the False Claims Act. Overpayments have to be returned to the government within 60 days of identification. That basically means that anytime that we find an overpayment, even if it was an honest mistake, we have 60 days to get that money back to the government. If we happen to go to the 61st day or beyond, what was an honest mistake could potentially turn into false claims liability, and we could be hit with extra penalties for not getting it back to the government on time. So here are some examples of knowingly. Remember, we said that the False Claims Act prohibits providers from knowingly submitting a bill that's false or fraudulent in nature. So the first definition of knowingly is you had actual knowledge of the falsity of the information. The best example of this is perhaps you have a patient that comes in and a few years goes by, they don't return, but you have their medical information and you put their information on a new claim. They've never come in for any new services, but you put their information on a new claim and you send it to the payer because you want to be paid for services. And that's obviously false and fraudulent in nature. There were never any services rendered. That's probably the most egregious example of knowingly. But the government also defines knowingly in various other ways as well, because for a long time, providers said, okay, well, I'm not necessarily knowingly doing anything wrong because I just won't audit any services that I provide or any bills that I submit. I won't try to look to see if I'm doing the right thing. The False Claims Act was actually amended to include what's called deliberate ignorance or reckless disregard. And they're both actually definitions of knowingly. And what basically they both mean is that if you bury your head in the sand, if you don't do anything to bill correctly, if you're not intending to do the right thing by looking into your claims, doing your audits, putting appropriate billing safeguards in place like edits and things like that, you can't get around the knowingly standard just because you didn't look. Burying your head just simply isn't good enough. And so even by doing that, even if you didn't have any intention of doing anything wrong, you can still violate the False Claims Act and act knowingly. So penalties for False Claims Act violations can include criminal charges for conspiracy to defraud. That's the most serious type of false claims violation. This is where basically you conspire and your intent is to defraud. And I would say probably the first definition of knowingly we talked about on the previous slide is most similar to this, where you're intending to defraud, you take someone's Medicare or Medicaid number, you put it on a claim, services were never rendered. Where there's less intent to defraud, there's less conspiracy to defraud, you can also be charged with civil penalties. Civil penalties can add up though as well. Civil penalties under the False Claims Act can include 3 times the original amount of the claim, plus almost $11,000 to almost $23,000 per claim. So if you think about how there could be an issue that goes on for maybe 6 months or a year or multiple years, and you come to a realization that there's an issue and you don't refund it, or you don't want to refund it and the government finds out, you can be hit with civil penalties. And you think about the claims that could go on for years and years and years time, that could be the $11,000 to $23,000 per claim, plus 3 times the original amount of the claim. It can add up to be a significant amount very quickly. The False Claims Act also provides protections for whistleblowers. And essentially what this means is if you were to raise a concern internally at GoHealth and no one were willing to listen to you, what you could do is take your concern outside of GoHealth and essentially file a federal lawsuit bringing your allegations forward. If the government decides that your lawsuit has enough merit, they may intervene on your behalf, argue it for you, and at the end of the day, if any money is recovered, you would get a portion of that money. All the while, you would not be able to be retaliated against or anything for bringing your concern forward. So updates and enforcement actions to the False Claims Act. Some changes to the False Claims Act for 2017. Overpayments are considered identified when the final repayment amount is known. Remember, that's important because once a claim is identified, we have 60 days to refund that money to the government. If you go to the 61st day, the False Claims Act could be implicated. Some enforcement actions in 2015, the Department of Justice opened 983 criminal fraud investigations during the year, and they also excluded 4,112 individuals from participation in Medicare. Exclusion is a really favorite tool that the government uses lately to penalize individuals acting inappropriately in the Medicare and Medicaid systems. Essentially what exclusion does is what we talked about in the previous section, where we screen everybody against the list of excluded individuals. We do that because the government, if you've been involved in fraudulent behavior or something along those lines, the government will use its exclusion authority to put you on a list and say that you can never work for any company that ever does business with Medicare again. And so it's really kind of a career killer if you're put on this exclusions list. But they, in last year alone, put over 4,000 individuals on the list. Fraud recoveries in 2016 amounted to $2.4 billion, and this is across the board in fraud judgments and settlements. So in just 1 year, the federal government stopped $2.4 billion in fraud in the Medicare and Medicaid systems. And then at the bottom, you'll see that there was the largest single-day national sweep in history of individuals that were arrested in 2016. Basically, the federal government cooperated with the state governments, and they coordinated their efforts. And in one single day, they went in and arrested 301 individuals, including 61 healthcare providers, so doctors, nurses, physician assistants, nurse practitioners. The individuals that they arrested were alleged to be involved in almost $1 billion in healthcare fraudulent billings. So some examples of problematic billing. Billing for services that aren't provided is a huge issue. And again, that's probably the most egregious example I can give you of what would be considered Medicare fraud or Medicaid fraud. There's some other examples though that we should look at. Unbundling of services and improper use of modifiers is a continual risk area that the government's looking at, and they do proactive audits in this area because basically what they want to see is, are you unbundling services unnecessarily to increase payment? A great example of this is where basically you append a modifier, and there are modifiers that do this, that unbundle services. So you have like a global surgery period that includes, let's say you're going in for surgery and the surgical payment that the physician receives for doing that surgery includes certain services after your surgery. So for 10 days after your surgery, any follow-up care that you need related to the surgery is covered under the payment, and there really shouldn't be any additional payment. The physician can, through the use of modifiers, inappropriately unbundle those services that you receive after to say, no, this is distinct and separate from the surgery, and I want to be paid for this. And the payers, including Medicare and Medicaid, rely on those modifiers to know if it's separate and distinct. So if you're improperly using that and labeling it as separate and distinct, they may make a payment for that, and that payment would be inappropriate because the theory is you've already been paid under the payment for the surgery itself. Medically unnecessary services are also a hot item for the Department of Justice and the Office of Inspector General. The Medicare and Medicaid services have said that the overarching criteria for any Medicare payment is medical necessity. The government does not pay for services that are not medically necessary. A great example of this is if you come in for a cough and the provider is doing x-rays of toes. Those things are obviously, the x-ray is probably not going to be medically necessary because you're coming in, your complaint is chest, something in your chest. There's no issue with your foot. Your foot's completely fine and healthy. There's no reason to do that x-ray of your foot or of your toes. That's completely not medically necessary. And Medicare and Medicaid say they will not pay for those services. So using students and residents in unauthorized ways is another risk area. Specifically, what we're talking about here for students are PA and NP students, so physician assistants and nursing practitioner students. And essentially what the rules state for around this is that anything that a physician assistant student performs or that a nurse practitioner student performs is not billable. So if there's a student in our clinic and they do a laceration repair, we can't bill for that. There are certain rules around if, like, for example, an E&M is performed and the provider goes back in and reperforms all elements of that E&M, that would be billable because we're really billing for the services that the provider provides, not the student. Similarly, residents have certain rules on how we can use their services or bill for their services. Essentially, there are certain supervision guidelines that we have to follow. They get pretty complex, but we have to make sure that we get that right every single time in order to bill for the services that residents provide. And then finally, lack of documentation to support charges or level of care. This goes back to what we talked about earlier, where the golden rule in billing compliance is if it wasn't documented, it wasn't done. And so again, this reinforces that concept. Anything that's not fully documented in the medical record, we could provide all the medically necessary care in the world, but if we document none of it, then we can't charge for any of it, because if we ever get audited, the government's going to say there wasn't documentation, you shouldn't have been paid, we want the money back. So here are some billing policies and procedures I want to make you aware of. We have a compliant billing practices policy, which basically says that we strive to bill accurately and in compliance with the various reimbursement rules every time, just like we started this section. We want to make sure that all of the documentation is in the chart, our coding reflects the documentation 100%, and that the claims that we submit are completely accurate so that the reimbursement we receive is 100% accurate as well. The compliant billing practices policy discusses the various anti-fraud laws and regulations that are out there, including the False Claims Act, which we talked about a bit ago. And then there are additional policies and procedures that our billing office has around our billing program, our coding program, reimbursement policies, and more. And all that can be found on the SharePoint site as well.